So they're going to populate. So we're just going to let everybody get into the meeting. Go. Just takes a minute for everything to populate.
All right, well, sorry for the technical difficulties. Hopefully we'll be starting soon.
Don't worry about it. Yeah, I'm just, everyone's just getting in. So it's just letting everyone in. Hello, folks, if you're just staring at me on the screen, we're just waiting for all the participants to get in. I'll start by apologizing for the timing delays on today's webinar. It happens, there was just some miscommunication, but we're here. And of course, and now we're having technical difficulties. So it must be a full moon today, or it's not the 13th of any kind. So, but we're making it work. So we're just gonna get everyone a chance to get in, and then you can see Dr. Hsia's slides. Sadly, his camera's not working, so we won't be able to see his wonderful face, but that's okay. At least the slides are going.
It might be better for all of you that you can't see my face. So,
so we'll get started then, because we are a little bit behind time. So thank you again, everyone, for joining us today. Today we're going to be talking about cytogenetics and molecular testing in MDS. My name is Kimberly Brunel, and I am the Ontario Patient Liaison with AMAC. In case you don't know who we are, we're a leading funder in research into bone marrow failure diseases in Canada. Our organization supports patients and caregivers from across the country who are living with aplastic anemia, myelodysplastic syndrome, and PNH. I am very pleased to be joined today by Dr. Hsia. If you've watched our webinars before, he is not new to us, and Dr. Hsia is a consultant in internal medicine and hematology at the London Health Sciences Centre and the London Regional Cancer Programme. If you have any questions at all during the presentation, you can always type your question into the chat or the discussion box, and we'll try to get to them definitely by the end of the presentation. And if you want, you can also just hit the raise your hand button, and we can unmute you if you actually want to ask your question directly to Dr. Hsia. As always, this webinar is being recorded, and so you can always watch it back some other time. It'll be available on our website. So without further adu, Dr. Hsia, I'll pass it over to you.
Wonderful. Thanks so much for the introduction, Kim, and hopefully you guys can all hear me okay. Thank you to Kim and AAMAC for sponsoring this and for inviting me. It's always been a pleasure to chat with folks previously in person, as we used to do it in a little center in London, but we have to do this virtually for the last few times. So thanks again. This time we thought we would chat a little bit about cytogenetics and molecular testing, particularly as it relates to MDS, or myelodysplastic syndrome, as there are newer therapies out. So this is, I think, exciting times for not only physicians, but also patients, because there are newer therapies. To get started, welcome to London. If we were doing this in person, it is a lovely, lovely city. And what you're seeing here on the right side is the Forks at the Thames and nice walking trails during the springtime, as you can see, and then during the fall, beautiful colors in the cityscape. The objectives for today, we're going to try and discuss cytogenetic and molecular testing, understand the importance of these testing in MDS, and describe the potential impact of these test results on particular types of patients with MDS. At any time, if you do have questions, please feel free to speak up or put it in the chat box, and we'll try and cover some of those questions at the end. But like anything, we should start from somewhere, and somewhere is with your blood cells and where they come from. So as you know, in our blood, it's not just fluid that runs around in there, but there are trillions and trillions of different types of cells. And those cells are mainly made up of red blood cells and platelets and white blood cells. So, and they're in a solution called plasma. But if we took a sample of your blood and spun it down, the heavier cells like red blood cells go to the bottom, and the smaller, lighter cells like white cells and platelets are in a little buffy coat in the middle. And then the remainder is that liquid plasma that's there. When we look under the microscope, we can see these microscopic cells come to life. And in a cartoon depiction of that in your blood vessels, in our blood vessels, blood then is not just a liquid, it's made up of all these trillions and trillions of cells. Again, white blood cells that are there to help fight off infections, red blood cells that carry the oxygen around the body, and platelets that help form a clot. And they're all very essential functions in our bodies. And where they come from is a factory called the bone marrow factory. And the bone marrow is essential. So where are these bone marrow factories found? Well, if we're a child, bone marrow is throughout our bones, throughout our skeleton. And that makes up the red part of the bone marrow. And that's where we have the production of all of these white cells, red cells, and platelets. But as we age over time, you can see this is an example of an adult bone that in the middle, in the middle of the marrow, it starts to scar down, or it's replaced by fatty tissue, so by fat cells. And the amount of red marrow where our cells are made becomes less and less towards the end of the long bones, or the pelvic bone, or the breastbone. So over time, the skeleton gets replaced by the fatty cells, and there's fewer and fewer parts of our bone marrow making these cells. And how are these cells made? How are these red cells, platelets, and white cells made? Well, they're made in the bone marrow starting from a blood stem cell. So a blood stem cell has the capability of continuing to grow and divide and make more of itself. But eventually, as it grows and divides, it could then become more committed to a immature myeloid stem cell or immature lymphoid stem cell. The myeloid immature stem cells eventually divide and grow and eventually become our red cells, our platelets, and some of the white blood cells. The lymphoid stem cells grow and divide and eventually become our white blood cells that are called lymphocytes. But this is the magic that happens within the bone marrow. So how do we know your bone marrow is doing well or not, or someone's bone marrow is doing well or not, is to actually interrogate or take a sample from the bone marrow. And this is how it's done, a bone marrow aspirate and biopsy. Unfortunately, there is no non-invasive way of doing it. There's no Star Trek way of scanning a scanner over the bone marrow and figuring out what's happening inside. You have to take the cells out of the bone marrow, and you can see you have to take a needle, push it through the hard part of the bone into that soft marrow and suck out some liquid, that's the aspirate, or take a core biopsy out, and then you can see how those cells are working. And within those cells, what controls it is the genes at the genetic level. And we're going to talk about cytogenetics and molecular. Every cell in our body which has a nucleus, and this is an example of a cell with a nucleus, the genetic materials are within that nucleus, and that genetic material controls the actions of all these cells. So in this cell, if you look deeper still within the nucleus, you can see that the genetic material is wound up in these little packages called chromosomes. And if you were to unwind these chromosomes out, you will eventually see the genetic material of life, which is what our DNA is composed of, these long strands of genetic material. In the human body, we have in every cell that has a nucleus, typically 23 pairs of chromosomal information or chromosomes. And so you can see here chromosomes outlined from 1 all the way to 22. These are called our autosomes. And then we have a pair of sex chromosomes. For women, it would be XX, and for men, it would be XY. This would be a typical example of what a chromosomal set looks like in a cell in a male individual. Where do these genes come from? We all have 2 sets of genes in the nucleus of each cell that has a nucleus. One set of that genes comes from our father, and the other set comes from our mother. But genes and mutations can occur. They can occur because it's inherited. So that's the genetic material that you're getting from your parents, or it can be acquired. Inherited genes means that that genetic material came from either your father or your mother. So here's an example. Pretend that the red or magenta colored gene is a mutation. And perhaps, let's say the father is a carrier and the mother is a carrier. Then there is a 25% chance that the child can have the unaffected genes from the mother and father. There's a 25% chance that they can have both the affected genes from the father and mother. And then there's a 50% chance that the child may be a carrier of that particular gene. So these are genes that are inherited and passed on from one generation to the next. But in myelodysplastic syndrome and other diseases, it can be acquired mutations. And what do we mean by that? Well, these are mutations that occur in the cells after birth from many different causes, whether it is exposure to chemicals, to radiation, to other chemotherapy. These mutations can occur also randomly during cellular division. Remember, in the magic of the bone marrow, as the bone marrow stem cell divides and grows and becomes another stem cell or more committed early progenitor cell, and eventually as it divides and grows and becomes other more maturing cells, it has to copy the DNA identically from one stage to the next. And if a mistake happens, if an error happens, it can happen by random chance. Those are acquired mutations. Those are mutations that occur in the stem cell compartment or an early progenitor cell of the cells in your bone marrow. Those are not mutations that then get carried on to the next generation. Okay. So those are acquired mutations. What is cytogenetics? The cytogenetics is the study of these chromosomes that are in the nucleus of each cell. The study is trying to understand, are there any changes in the chromosomal structure, its location, or its function? And those mutations can occur in an acquired way in the bone marrow. One common example is the 5q deletion in MDS. And here you can see a complete structural change. If you have 2 normal pairs of chromosome 5 in the cells, in the stem cells of your bone marrow, then they should be very similar to each other. But in some individuals with MDS, they've acquired a mutation. In part of chromosome 5 here you're seeing, part of the long arm of chromosome 5, there's a short arm of a chromosome and a long arm of a chromosome. In part of the long arm, called the Q arm, there's a part missing. And that is an acquired mutation. This again is in the stem cells of the bone marrow that this is happening. It's not in the genes that were inherited from your parents. And these are not in the genes of the cells that would be passed on to the next generation necessarily. These are often acquired mutations. So this is one example of a 5q deletion in MDS. And this is another picture of an example of a 5q deletion. But MDS is more complicated than that. In most patients with MDS, there could be a cytogenetic abnormality, a chromosomal abnormality. In fact, in primary MDS, meaning that it came out of the blue, somebody who probably is in their 60s, 70s, or 80s, who've developed a diagnosis of MDS, a mutation occurred. The majority of patients will have a random mutation, and you can see abnormalities in chromosome 5 make up perhaps 8% or so of those with a new diagnosis of MDS. MDS can also, remember, be caused by other things other than random mutations. It can be, the T in here stands for therapy related. Perhaps they were exposed to chemotherapy or radiation or something that increased their risk of developing a mutation that led to MDS. And here you can see there's very few individuals with a normal cytogenetic pattern, but we can find the majority of these patients will have some sort of abnormal chromosome change, and abnormalities in chromosome 5 can make up 22% of those individuals, and abnormalities of chromosome 5 and 7 can make up another 24% of those individuals. Other than the general structural or major changes we see in the chromosomes, we can have mutations at a smaller, finer level. Maybe we don't see that a part of the chromosome is gone, but if you look deeper, maybe there are mutations at the very, very genetic coding level that's present. And this is molecular genetics, the study of genetic materials within the chromosomes. And these mutations, like those chromosomal abnormalities, have implications. It has implications on how likely your MDS is, whether it's more aggressive or less aggressive. It has implications now, we understand, potentially for targeting treatment for patients with MDS. So very, very important. One good example of a mutation that we now know has good prognosis is this example of an SF3B1 mutation. And this mutation is highly associated with something called ring sideroblasts. So in here, in the picture, what you're seeing is an example of a blood film, a bone marrow film of the cells when they suck out the liquid part of your bone marrow. And you're seeing each of these different cells in your bone marrow factory. And the arrows are pointing to some abnormal changes or dysplastic changes. And on the right-hand side, when you stain it with iron, what you're seeing here, the blue is iron. And there are iron in the mitochondria, these organelles, in each of these red blood cell precursors that seem to form a ring around the nucleus. And that's where it got its name, ring sideroblasts. And this mutation that's highly associated with ring sideroblasts called SF3B1 is a genetic mutation within the long arm here of chromosome 2. So when you look at the cytogenetics, the structure of chromosome 2, it looks like it's fine. But when you look at the molecular level to see if there's a mutation, you identify that that mutation is present, and that mutation is associated with this ring sideroblast. And it has now implications for management in MDS. So there are other mutations as well, and those mutations can impact how one does. There are good beneficial mutations called the SF3B1 mutation, but there are also bad mutations as well, like TP53, etc. You don't have to memorize these. And for now, there's no yet large validated models for prognostication that incorporates these molecular mutations or lesions. What that means is that right now, how you do if you have MDS is not based on the genetic mutations yet. It's based on how many cell lines are involved. So is it just your red blood cells, or is it more than just your red blood cells? Is it the cytogenetics that we talked about? Or is it related to how your bone marrow has those immature cells in there. So genetics will be coming down the line. But let's talk about MDS as well, just to refresh everyone. What is MDS, or myelodysplastic syndrome? Well, here's a definition that we still use for the last couple of decades or more, is that myelodysplastic syndromes form a group of clonal hematopoietic stem cell malignancies characterized by ineffective hematopoiesis in one or more cell lineages associated with peripheral cytopenias and risk of transformation to acute myeloid leukemia. Isn't that a big mouthful? And something you could put on your fridge and try and memorize. And so we're not expecting you to memorize this. We're not going to quiz you on it. The best way to think about MDS, I think, comes from my predecessor, Dr. Robert Barr, who taught me. And it was this, that he compared MDS factory to the Ford Pinto factory, I guess. I don't know what he had against Ford, but anyways, so the example was this, is that the bone marrow is like a car factory that might not be working quite as well. I've never had this Ford Pinto or know anything about it, except I guess its engine is quite combustible when it's injured or slightly bumped. And so it's defective in that way. And so if your bone marrow factory is making these cells, these red blood cells or white blood cells or platelets with defects, they're not going to survive quite as long. Maybe they don't even make it out into your bloodstream, so your red blood cells are low. Or maybe if they make it out into your bloodstream, into the highways of your circulation in those bloodstream, maybe they break down sooner, just like this Ford Pinto. And so when you take a blood test, a blood sample, and you look and say, you know, how many red blood cells do you have? Well, it's going to be much lower because they're all broken down sooner than they should be. Or in some patients with MDS, their white blood cells might be lower than expected, or their platelets might be lower than expected because they're not as effectively made. And that's where the term ineffective hematopoiesis comes from. They're made with defects. They're not very well made, and so they break down sooner. That leads to one or more of your cells, your white cells, red blood cells, or platelets being low. And that's what we mean by the term the peripheral, meaning in your blood circulation, cytopenias, the cells are low. But in these individuals, because they have these mutations, they're also at higher risk of becoming an acute leukemia called acute myeloid leukemia, or AML. Okay. So think about MDS as this factory that's not working quite as well. And it's a group of different diseases. It's not just one type of disease. And most individuals and the WHO, we would classify now MDS as a type of cancer of the bone marrow and blood system, where the cells are made with defects and they don't survive quite as long. And that leads to one or more of your blood cells being low. Again, it's not leukemia itself, but because there's a higher risk of it transforming to acute myeloid leukemia, it could be considered pre-leukemic. It is not one disease. Everyone who has MDS may behave differently. What is the impact of MDS? Well, MDS, unfortunately for the patient, it can lead to a poor quality of life because they may need time and commitment for getting transfusions. They can have complications then of those transfusions. With every transfusion, they're getting iron and they can become iron overloaded. They can have cardiorespiratory symptoms. And what we mean by that is if they don't have enough red blood cells carrying oxygen around the body, then their heart and their lungs have to work extra hard. They're going to become short of breath, have chest discomfort or chest pain. They may be hospitalized because of these cardiac complications. They could be hospitalized because they have an increased risk of infections, because again, maybe the white blood cells are low or the white blood cells are not working as well. They could be hospitalized because of increased bleeding because the platelets, which are there to help form a clot, the platelets are low or the platelets are not working as well. Or they're hospitalized, unfortunately, if the disease has transformed into an acute leukemia. And unfortunately, individuals with MDS do have an increased risk of shorter survival. The impact of MDS on society is that transfusion are not a free and unlimited resource. Transfusions come from volunteer donors who are willing to provide their blood, and that blood goes through a very rigorous process via the Canadian Blood Services to test it for all those things like HIV, hepatitis, to store the blood, to make sure that that blood gets to the right person at the right time. And then hospitalizations are a huge impact for society as well. So MDS is a huge impact for patients and society. So if you have MDS and your factory, your bone marrow factory is not working well, think about it as the car factory. If you need cars in the highways and those cars from your factory are not making the cut and they're breaking down sooner, well, one way to manage that is to import perhaps better cars. And that importation of better cars is transfusion. So you're getting a bag of red blood cells, hopefully better red blood cells from a volunteer donor. And for some people, they may need more transfusions than another. We have patients who are fortunate enough not to need transfusions with MDS. We have patients that may only need a transfusion once or twice a year. But unfortunately, on the other end of the spectrum, we have patients who need a blood transfusion of maybe 1 or 2 units of red blood cells, maybe once a week, once every other week, or once a month. There is no specific threshold for transfusions. You might say, well, when do I get a transfusion? Is it when my hemoglobin is slightly low? Is it when it is at 80? Is it when it's at 70? There is no one number that fits all. It's dependent on your hemoglobin level along with symptoms of your low hemoglobin called anemia. So for the patient where their hemoglobin is 70 and they can still do all their chores and stay active and jog and run, they may not need a transfusion until their hemoglobin is below 70. But for the patient who can't get out of bed when their hemoglobin is around 90, maybe they need a transfusion around 90. Okay. But the hope and the goal in the future and currently is that there are specific treatments depending on your age, your overall health, the stage of your MDS, and the type of your MDS. And the 2 types of MDS we're going to concentrate on relate to a cytogenetic abnormality and if you have these ring sideroblasts with or without this molecular mutation called SF3B1. For cytogenetics, for patients who have the 5q deletion, they may be a candidate for a medication called lenalidomide, we'll talk about. For patients with ring sideroblasts, and this may include 1/5 to 1/4 of patients with MDS, they may be a candidate for a medication called luspatercept. So lenalidomide, if your MDS or your type of MDS shows that you have the 5q deletion, then you may qualify for a medication called lenalidomide. And again, the 5th chromosome here, this is a cartoon representation, and this is what it may look like on the cytogenetic testing. If part of your chromosome 5, the long arm, again, that's the Q arm, is missing, then you have the 5q deletion. You can have just the 5q deletion, or you can have the 5q deletion along with other chromosomal abnormalities. Patients with the 5q deletion, it can make up, this is an example of this estimated 16 to 28% of MDS patients. These individuals may present with anemia, and usually it could be a macrocytic anemia. What that means is that your hemoglobin is low, anemia, and macrocytic, meaning that the red blood cells are a little larger than what they normally should be. They can have a normal to elevated platelet count, and in the bone marrow, they may have increased micromegakaryocytes. That's a big, long name. Megakaryocytes are the granddaddies of our platelets. They make, or platelets are from the megakaryocytes, but micro, meaning that they're smaller than what they should be. It's a clue that they could have the 5q deletion. Usually their bone marrows are hypercellular, meaning there's a lot more production of those cells. So the factory is making tons and tons of those cells, but remember, they're defective. Usually there's a female preponderance, so more women than men, and usually individuals 65 to 75 or older. But having the 5q deletion suggests a favorable prognosis. They often do better and live longer with that than compared to some other types of MDS. Here's an example of what that bone marrow may look like with these small micromegakaryocytes that might be present in there. You do not need to know that, but this is just another example of what chromosome 5 looks like and where the genes that are affected in the long arm of chromosome 5 might be. In these individuals, they may be sensitive to EPO, erythropoietin. Erythropoietin is a hormone that our kidneys make in response to low oxygen. In individuals with MDS, they may be put on a medication that is a recombinant form of this hormone called erythropoietin, and they may respond by increasing their hemoglobin in response to that medication. Serum EPO levels, however, are usually elevated in these patients, and because of that, they may not respond so much to this hormone erythropoietin. Because of that, we need to consider another medication perhaps, and that other medication is called lenalidomide, which has been around now for about a decade. So lenalidomide in clinical trials has been studied in MDS. This was a phase 2 trial called the MDS 003 trial, and they enrolled mostly in the United States 148 patients. Average age was 71 years, but you can see they included a whole range of ages from 37 to 95-year-old patients. And patients were transfusion dependent, meaning that they were dependent on those transfusions, and they often received more than 2 units of red blood cells every 8 weeks. And they were in the lower risk category, meaning they had lower intermediate 1 risk MDS. And that is for another lecture, but the cytogenetics, a number of cell lines, and the immature cells in the bone marrow help us determine what risk score they are. And these individuals had the 5q deletion, but they could have just the 5q deletion by itself, or they could have other cytogenetic abnormalities. And they were given lenalidomide 10 milligrams oral daily for 21 days every 28 days, the so-called syncopated schedule. You're on it for 21 days, and then you take a break for the 7 days. So a 28-day schedule, and then you do it again in the next 28 days. You're on it for 21 days, and then you take a break for 7 days. Or they received 10 milligrams of this lenalidomide every day without a break. Okay. There's no placebo group in this phase 2 trial. But what they found was that everybody who received lenalidomide in either of those schedules, 64% of those patients, so 93 out of 148 patients, actually became transfusion independent, which is awesome, meaning that they did not require transfusions again. And of those who had the 5q deletion only, they had a better response of 69% compared to those who had the 5q deletion and another cytogenetic abnormality. About 49% of those patients responded, which is amazing. So there's a medication that helps those patients reduce their transfusions. There was a phase 3 trial. So this is a randomized, double-blinded, multi-center study called the MDS-004 trial. And it enrolled patients with the 5q deletion plus or minus other cytogenetic abnormalities. But this time they compared 2 arms to placebo. So lenalidomide, you could be taking the 10 milligrams 21 days every 28 days, or you could be taking lenalidomide 5 milligrams every day, and you compared it to the group that got placebo. So they got a pill, a sugar pill, basically. And then you can see in comparison to the sugar pill, the individuals who got lenalidomide, either this 10 milligrams, 21 days every 28 days, or 5 milligrams every day, became transfusion independent for over 26 weeks. More so in the lenalidomide arms, 56% and 42% versus only 5.9%. What that means is that this medication, this oral pill, lenalidomide that you take, whether you take it 10 milligrams or 5 milligrams, if you take it 21 days every 28 days or take it every day, you're more likely that it will help you reduce your transfusions that you need. And for some of them, can be lucky enough that they become transfusion independent, meaning they don't need transfusions at all during that period of time. Like any drug, even if you looked at aspirin, nobody would ever take aspirin if they looked at all the different side effects. But lenalidomide, like any drug, will have side effects. Some of the common side effects include fatigue, abdominal pain, muscle aches or joint aches, back pain, constipation and or diarrhea, dizziness, edema, headaches, insomnia, nasopharyngitis, so inflammation of that airway, nausea, vomiting, pruritus is itchiness of the skin and or a skin rash. Like any medication, it can also cause changes in your blood counts. So if your white blood cell count goes a little bit lower, then there's the risk of infection. So it's important to monitor for infections. It's important to speak to your doctor if you're on this medication, as your doctor will monitor you for these side effects, including blood work, looking at your white blood cells, your red blood cells, your platelets. They'll also look at your kidney function and your liver enzymes and speak to you about these side effects. But the trade-off is you have to look at a medication and balance the benefits, the potential benefits of maybe coming off of transfusions or reducing your transfusions, and the potential side effects. So the summary with lenalidomide is patients with MDS who have this particular mutation, the cytogenetic abnormality called the 5q deletion, and who require transfusions may benefit from this medication called lenalidomide. Again, it's given orally. It can be given in doses of 5 to 10 milligrams daily, or on a syncopated schedule of 21 days on and 7 days off in a 28-day cycle. You and your physician can monitor those side effects and blood work, and that's important. Any questions about that before we move on to the molecular?
I haven't seen any questions come through yet, Dr. Hsia.
Okay. Next, for the molecular, if you have myelodysplastic syndrome, MDS, in your bone marrow, and it shows these ring sideroblasts here, again, these iron staining rings, and or with this SF3B1 mutation, you may qualify for a new medication called luspatercept. And this is important because patients with ring sideroblasts are a fair size proportion of patients with MDS overall. 20-25% of MDS patients will have this. The majority of the patients with these ring sideroblasts that we've seen will have the SF3B mutation. And what's happening here is in these individuals, it's felt that perhaps these later stages of erythropoiesis, as we mature in the red blood cells, they're highly affected here, perhaps by inflammation and inflammatory proteins. These inflammatory proteins are called TGF-beta superfamily group of proteins. And what they do is that they signal, imagine these two blue balls here binding to the receptor, and they stimulate and cause a cascade of signaling proteins to prevent that cell from maturing into their mature red blood cells. What happens with this drug, luspatercept, is it almost looks like this receptor forms like a decoy almost, and the proteins, the inflammatory proteins, these TGF-beta proteins, bind to luspatercept instead of acting on the red blood cells. And what that means is that the red blood cells are now free. These red blood cell precursors are free to continue to grow into their mature red blood cells. So whereas EPO, erythropoietin, remember, it stimulates the bone marrow to stimulate production of red blood cells. Its effect is earlier on in the immature red cell lineage, from a stem cell to a red blood cell. Luspatercept effect is more on the later stages of erythropoiesis, of generation of erythroid red blood cells. Where was luspatercept studied? It too now, there's a phase 3 large double-blinded randomized placebo-controlled trial called the Medalist trial. And they enrolled patients with MDS who were transfusion dependent, who were in the lower risk groups, and who had ring sideroblasts plus or minus this SF3B1 mutation. The requirement was in the bone marrow of those individuals, they had ring sideroblasts of 15% or more, or 5% or more with this mutation. And they were randomized 2-to-1 to receiving luspatercept injections versus placebo injections. That means 2/3 of the patients enrolled received this study drug, and 1/3 of those patients enrolled received placebo. And their endpoint was looking at who became transfusion independent over an 8-week period or more during their study period of 1 to 24 weeks of observation. And what they found is that patients who received these luspatercept injections every 3 weeks did much better than those patients who received placebo injections every 3 weeks. So here you're seeing, you might say, well, this is not as impressive. Only 37.9% of patients, so 58 out of the 153 patients, became transfusion independent compared to placebo, which was 13%. But in these patients, remember, they've already had tried an erythropoiesis medication, EPO, erythropoietin, before, or they were not candidates for erythropoietin. And here you see a good graph of what the hemoglobin looks like over time. So you're seeing from baseline, when they both started, both groups were very similar in their hemoglobin. But when you see the blue line, luspatercept, you see their hemoglobin is increased and it stays increased compared to those who had placebo. There's a slight increase, but it's much lower than the luspatercept arm. So even if they don't become, an individual doesn't become transfusion independent, it may increase their hemoglobin, increase their quality of life by feeling better, and it may reduce their transfusions even if they're not transfusion independent. Like any drug, luspatercept also has side effects. Common side effects it's listed in its product monograph include fatigue, diarrhea, nausea, constipation, dizziness, headaches, muscle, back pain. But something unique here is blood pressure increase. On average, the blood pressure might increase by about 5 for both the upper and lower numbers, called the systolic blood pressure or the diastolic blood pressure. And it may have an effect on the kidneys and liver as well. Because it's an injection, imagine you get any injection, you can have a reaction at the injection site. So you can have an allergic type reaction that's reported about 4 to 6%, but all were non-serious types of allergic reactions, perhaps some redness, swelling, hive-like things, but nothing serious. And also important to monitor for infections as well. So if you're started on this medication, it's important that you and your doctor continue to monitor for these side effects and that you have your blood work and blood pressure checked as well. For your blood pressure, you may need to see your own family physician to either increase your blood pressure medication if you're on a blood pressure medication, or some people may need to start a blood pressure medication. But your hematologist will continue to monitor your blood work, including your white cells, red cells, and platelets, and kidney and liver enzymes as well. So the summary for this is that the Medalist trial would suggest that patients with lower risk MDS patients who had the ring sideroblasts can be treated or may be a candidate for luspatercept, and that might reduce the number of patients who are needing transfusions. So they can achieve a red blood cell transfusion independency, or they can have a reduction in their transfusions, or their hemoglobin is increased compared to placebo. And in the Medalist trial as well, the erythroid response to their hemoglobin is durable that we saw. It was increased and it was sustained with approximately 40% of those patients. We saw 37.9% were transfusion independent and sustained at 12 months of treatment. Luspatercept for that patient population was well tolerated, and so it represents a potential new therapy for patients with lower risk and ring sideroblasts who have MDS. So what's exciting about that is that this is a new therapy that was recently Health Canada approved, and the pharmaceutical company, while waiting for the provinces to provide provincial funding and criteria for provincial funding, has rolled out a patient support program. So if you are somebody with this MDS with a ring sideroblast in a lower risk group, you may potentially qualify for this medication. And you talk to your family doctor and look at the potential pros, so the potential benefit of this medication to reduce the transfusion burden, to increase your hemoglobin, and then you weigh that against the potential side effects of this medication and the fact it's an injection medication every 3 weeks. And if you qualify and you are able to get access to this medication, it may be something to consider with your hematologist. So in summary then, myelodysplastic syndromes, it's not one disease, it's a heterogeneous group of bone marrow disorders that some of us go as far as calling it a type of cancer of the bone marrow, where the bone marrow, again, remember, is defective and it's not making the cells quite right. And that leads to your blood counts being low. The management then, understanding that and understanding the molecular and cytogenetics, is based on how severe your disease is, based on those immature cells called blasts in your bone marrow, the number of cell lines involved, and now understanding that there are genetic and molecular tests of your bone marrow. And if you have a certain subtype of MDS then, the specific examples are if you have the cytogenetic abnormality of MDS called the 5q deletion, it confers a good overall prognosis, and it confers a good response to a drug called lenalidomide. The trade name for it is Revlimid. A specific example of a molecular genetic abnormality in MDS is those individuals who have the ring sideroblasts. Remember, again, 20 to 25% of those patients, of MDS patients, will have the ring sideroblasts, and a majority will have this SF3B1 mutation associated with it. Those individuals overall have good prognosis, but now they may also have good response to a new drug called luspatercept to reduce their transfusion burden and increase their hemoglobin and perhaps feel better. Luspatercept is the trade name for it that you might hear about is called Reblozyl, and it's recently Health Canada approved, but the provinces do not yet have a funding model in place. But the company that makes this medication has a patient assistance program rolled out recently. And it's as recent as a couple weeks ago. That's how recent we're talking about. So I will end by saying that the hope is that, the bone marrow factory, we struggle and we're struggling and still learning a lot about understanding our bone marrow factory from both the looking under the microscope, looking at what it looks like, but understanding the cytogenetics and molecular. And perhaps one day in the future, we will be able to change that bone marrow factory, make it better, make it so that all of these red blood cells, white blood cells, and platelets are coming out and they're formed normally and they can function better. So with that, I will end the talk, but open it up for questions.
Thank you, Dr. Hsia. That was great. I know it definitely answered a few questions that I had. If folks have questions, if you could type it in either to the question box or the chat box. I see one already, Dr. Hsia, and just about the patient assistant program for luspatercept. How do we take advantage of that? Is that through our family physicians? Is it through hematologists?
Yeah, that's a really good question. Right now, the company that makes Reblozyl has come up with a patient assistance program, and it is best to go through your hematologist who understands your diagnosis of MDS. The reason for going through your hematologist is because your hematologist has the information on the type of MDS that you have. Again, remember, you have to confirm that you have MDS. 2 is you have to then figure out what stage of your MDS it is. And so your hematologist will talk to you about what stage you're at based on your test findings. And then in order to qualify for that medication, your hematologist will have the information on the bone marrow and molecular testing to see if you actually qualify for this medication. And then your hematologist will then go through the paperwork and then send the application off for the patient assistance program, if that helps.
I think so. That's great. Thank you. Derek has a question here. What is happening for patients with a RunX1?
That's a good question. So unfortunately, right now, we are still in the stages of looking at the other molecular mutations, including TP53, ASXL1, RunX1, you name it, understanding how it impacts MDS from both the diagnosis stage, the staging, because the staging currently does not include your molecular genetics, but one day it will. It's being studied. And then finally, does it impact your treatment? Because perhaps those specific gene mutations will tell us that perhaps you're in a higher risk group. And so we should be looking at other directions in management. So perhaps somebody who is younger and fit for a stem cell transplant with a higher risk mutation, they may need to be considered for stem cell transplant earlier than later. But that, again, I think is important for you to have a sit down with your hematologist and say, what does this mean for you? Because it may be very different than somebody who is 90 years old who has the RunX mutation, the SF3B1 mutation, or the TP53 mutation, or a combination of those. Okay. So it really depends on the person, their other medical health issues, their stage of their MDS, even their other cytogenetics and molecular that can interact with it, and also the need for transfusions, as you can see in here.
Okay, great. Derek, if you have any follow-up questions, feel free to type that in. Okay, so David wants to know, do you recommend molecular genetic testing for all MDS patients?
That's a good question. So again, David, thank you for the question. Right now, it is not necessary for every patient because we don't understand it too well, and it may not change your management, meaning that if we found the RunX1 mutation, or if we found the TP53 mutation on its own, it may not change your management at all right now. Perhaps in the future, if we have it in a staging system, a scoring system that says, aha, you have this particular mutation, we have a specific treatment for you, or you have this particular mutation, you're better off getting a stem cell transplant earlier than later. At that point, then molecular genetics should be tested for all MDS patients. But right now, it only provides additional information, but it doesn't have the ability to change management in most MDS patients. So where it might make a difference is again in luspatercept. So in luspatercept, if you have more than 5% ring sideroblasts, but you have less than 15% ring sideroblasts in your bone marrow, then you may need molecular testing to see if you have the SF3B1 mutation, to see if you fit the category of those patients in the Medalist trial, and you may benefit from luspatercept then. So it's very specific to individuals with MDS. But right now, as a general test for all MDS patients, it's not going to change management for most patients.
That's a good question. Thanks for that, David, and thanks for the answer, Dr. Hsia. I've often wondered that question, and I've received that question quite a few times. And so it really sounds like it's just dependent on what type of MDS you have or how it presents as to whether a hematologist would suggest this type of testing. Am I correct?
Yes, that's right.
Okay. And if somebody wanted to have this testing done, would they just simply need to ask? Would a hematologist say yes or no? Or how would that work?
It also depends, unfortunately, on the availability of the testing. So not all centers, and it's not as easy as just going out and getting it done in a peripheral test site. So only certain centers have specific molecular testing. You can have specific molecular testing for the exact gene mutation you're looking for. So there's a specific mutational test for SF3B1. Or some centers are lucky enough to have a panel of molecular mutations. Those panels can include a number of these MDS mutations, or it can include a whole array of other mutations that we even have no clue what they mean in MDS. And so those are often called myeloid NGS, so next generation sequencing testing. And unfortunately, that's only available in certain centers, not all centers. So even if you wanted your hematologist to send it off, they may actually need to contact another center in another province to test you.
Okay, that's really helpful. Thank you. Gwen has a question. Gwen has had MDS RARS for 14 years. 12 years now she's been on EPREX, has increased from 40,000 U to 60,000 U 4 years ago. Is there any value in getting tested for SF3B1?
Thank you for the question, Gwen. The answer is that for you, you don't have to get molecular testing for SF3B1. As soon as you have ring sideroblasts, so RARS was an older term based on the French, American, British classification. It stands for refractory anemia with ring sideroblasts. Then along came the WHO, or World Health Organization classifications, and the most recent iteration is the WHO 2016 classification. And for that, we just say myelodysplastic syndrome, or MDS, with ring sideroblasts, and it could be one lineage that's involved, a single lineage dysplasia. And for those individuals, like yourself, you would be a candidate for luspatercept. You don't even need to have the molecular testing done for SF3B1. It's those individuals that did not meet the definition of ring sideroblasts, but had a little bit of ring sideroblasts, over 5% in their bone marrow, but less than 15%. So you would have had 15% or more to call it ring sideroblasts. But it's for for the gray area, for those individuals with more than 5% ring sideroblast, less than 15%, that the SF3B1 mutation may be beneficial for them to know, because in that case, they may then qualify for this medication. So in your case, you can have the molecular testing done for your own information if your hematologist has access to that. And the majority of patients with ring sideroblast will have this mutation, but it's not going to change your management.
Okay, thank you. Gwen, if you have a follow-up question, feel free to type that in. And I think we have one more question I see here. Do you offer telemedicine consultations, Dr. Hsia? And if so, how can people reach you?
Oh, that's a good point. So during the pandemic, as you know, I think everybody's gone to kind of telemedicine consultations. Yeah. And so I started helping out with e-consults and things like that, where family physicians type in a little note or question, and I try and respond back a bit. But I have not yet set it up as a virtual telemedicine for individuals outside of our region. So we do quote unquote telephone consultations for patients where their family physician has referred them through, and for example, travel is difficult during the pandemic, or they would prefer not to come see us in person, then we try and set up a telephone kind of consultation with the patient and their family and so forth. But I haven't set up a formal telemedicine consultation, sorry.
Okay, no problem. If someone wanted to reach you, would they just do that simply through the London Health Sciences Centre?
Oh, for sure, yeah. So if you're in our region and would like to chat, I would be more than happy to just have your family doctor refer to me. Or if you just have a straightforward question, I guess there are no straightforward questions, perhaps. I apologize for that comment. If you have a question, maybe reach out to Kim, and Kimberly can email me, and or just email me directly, and I'll try and email you back.
And you can reach me at Ontario Support, and I've just typed that into the chat box, ontariosupport@amac.ca. If you have any additional questions, I can connect you with Dr. Hsia that way as well. So I don't see any more questions. Thank you so much, Dr. Hsia. This was great. I've been really wanting to have this webinar for quite some time. This has been a hot topic, and I think you covered it really well and answered a lot of great questions. So I thank you so much for your time today. And I thank all of you for being with us and for being patient with the time issues we had today. If you have missed something, or if you want to rewatch it, again, this is always recorded and you can go back on our website and view it at any time. Have a great Saturday, everyone. Thanks for coming.
Thank you for having me. Have a great weekend, everyone. Take care.
Thanks, Dr.
Stay
Hsia.
safe.
Bye, everyone.
Bye-bye.